So the Asia-Pacific Ophthalmic Trauma Society, which I am the president, Dr. Rupesh Agarwal and Dr. Andrews from Argentina has made eye gates for entry. So Dr. Aditya Jyot is a part of that. So the whole idea is to have a standard classification so that we can talk to each other, and mainly for publishing. So now from the Asia Pacific Ophthalmic Trauma Society we are publishing. There is an Okay, thank you. So I'm managing ophthalmic trauma is a passion for me right from my undergraduate days, because I grew up in the government eye hospital seeing trauma. So my talk is on salvaging, on unsalvageable, operating on no PLIs. So thanks to Ferenc Kuhn, and I don't have any financial interest. So thanks to Ferenc Kuhn, the president of International Society of Ocular Trauma, and my incoming president of ISOT is my friend who is a professor in University of Hull. So the whole idea is, I think when the trauma happens, that's the only place where we can operate on no PLI. So extreme trauma can include any of this, and then so the main idea will be to construct an eye when an eye is useful, preserve the eye anatomically, and keep the chance of a functional improvement irrespective of an initial complete functional loss. So that's why any bad injury, I say don't do primary enucleation, do something. And recently, about during the COVID, there was a bike accident, and somebody called me. The patient was admitted at night 1 o'clock in Hiranandani Hospital, and they said the eyeball is hanging. So I called the surgeon in the night 1 o'clock and said, do something. And I know that you may not be able to preserve the vision, get back vision, but do something. But somehow they said they could not put back the eye. In the morning when they called me, they said they have enucleated. I felt very bad, because the same patient came to me a few days later, asked whether anything can be done. So once the eye is enucleated, you can't do anything. And that's why I think in 1984, despite the common strategy, Dr. Michael Belkin, he is now 80, and he is still, I saw him recently presenting a paper in RO, advised not to enucleate an injured eye only because of the risk of sympathetic ophthalmia, and as long as the patient can be kept under observation. So nowadays with the steroids, we can make sure that even if sympathetic ophthalmia happens, you can treat them. Only thing is, you also have to know that post-vitreous surgery, I have faced sympathetic ophthalmia rather than post-trauma. But I think we have to know sympathetic ophthalmia can happen, and so one is to prevent while doing the repair, not to have the UVL tissue in the wound so that it does not produce the sympathetic ophthalmia. And you should have the earliest sign in case, for example, 30 years after the injury also sympathetic ophthalmia has been reported. I had a patient who had multiple vitreoretinal surgery for retinal detachment, and she was a young girl. She came with a difficulty in reading at the age of 18. So I knew it was the early sign of sympathetic ophthalmia. I referred him to Dr. Bishwas, who is here, one of the authority. He treated with steroid and the anti-mitotic drugs, and treated the sympathetic ophthalmia. The eye is having 6/6. So any eye that had lost the ability to perceive light was considered to be non-repairable in those days. But now, this is again a study published almost 24 years back by Ferenc Kuhn and Bob Morris, who was the president at that time. It was only 20 years ago that Morris reported on their attempts to reconstruct 11 eyes with severe ocular trauma that could not perceive light. The authors succeeded in restoring some function in 7 of the 11 cases. And according to an analysis in the World Eye Injury Registry, 28 eyes of no perception of light in eyes which a reconstruction was attempted. 21 patients regained light perception, and 2 ambulatory vision below 20/200. This was again published by Bob Morris. And why I am telling this is, in 86, when I was a consultant in Shankarnath, the fellow saw a child with a 6 years old with a vitreous hemorrhage with no PL, and sent the patient back. And somehow they went to many people and came back again and requested for an appointment with me again. And because of this, I operated, and you won't believe the child got 6'6", because assessment of no PL in a child was a problem. And I think just because only in trauma with no PL we can operate, and you can imagine the child got 6'6" vision, otherwise the child would have gone blind by not operating. So we need strategic thinking in ocular trauma, and that's what Ferenc Kuhn says. This is a systematic approach, must have its basis in the scientific literature and genuine personal experience, and no dogma involved. And I fully agree with Ferenc Kuhn that the surgeon must not act on a trial and error basis, but according to the plan. So it's like playing soccer. When you play the opposite team, you don't know. And same thing here with the trauma, you don't know what are the problems happening inside the eye. Thus, the decision when to perform vitreous surgery will therefore continue to be made by individual surgeon depending on each patient. So I'm going to talk on this subject with the extreme trauma with the foreign body, suprachoroidal hemorrhage, and endophthalmitis. So immediate vitrectomy is indicated for post-traumatic endophthalmitis or intraocular foreign body with high risk of infection. So these tendencies usually occur in young males. Retained intraocular foreign body occur in 5 to 40% of all open globe injuries, and overall 20 to 40 or greater visual acuity can be expected in about 71%. 18% of the posterior segment trauma will have a foreign body. It represents a true emergency. It could be metallic, magnetic or non-magnetic, and non-metallic, and also like the caterpillar hair, nylon, non-metallic like cilia. So again, the removal depends on the persistent inflammation, mechanical damage, and the intraretinal foreign body has a hazardous because of the risk of retinal detachment. And I'm just showing you a 25-year-old had a firecracker injury with best corrected visual acuity with no PL, or rather PL with inaccurate projection, diagnosed the intraocular foreign body in one in anterior chamber and other in retina, and surgery. So you can extend it. So this is not a free paper, so 6 minutes, Dala. Okay, no problem. So surgery, diagnosed with intraocular foreign body, one anterior chamber and other on retina. Surgery was planned in 2 sittings. The primary wound repair with the intracameral foreign body removal, intravitreal ceftazidime and vancomycin, followed by lens aspiration and 23 gauge pars plana vitrectomy with the intraocular foreign body removal. So this is after 1 month after the follow-up with the best corrected visual acuity was counting finger 1 meter. But for this you have to work a lot, do several surgeries, but I think it's worth it. Post-traumatic infection endophthalmitis occurs in 2 to 7% of all intraocular injuries, and surgical management is vitrectomy. So the principle is to clear the media, remove the potentially harmful organism load, and simultaneous antibiotic delivery, increase availability and penetration to retina, and removal of the vitreous scaffolding so that traction retinal detachment can be avoided. So vitrectomy many times have to be done with the temporary keratoprosthesis because the cornea is involved, and you can see here a 24-year-old male with a trauma with stone injury 20 days back earlier, and primary corneal perforation done 3 days following the injury, and perception of light was doubtful. Anterior segment had corneal abscess involving the whole of cornea. So one lesson from this patient is whoever sees the patient anywhere in any remote part of the country, I think should do a good wound repair immediately. I know sometimes in a small place where there are only ophthalmologists available and they are worried. I think you have to develop a rapport with the patient, which is difficult. It will take time. Can convince the patient that initial repair is important. There is no guarantee, and you can tell that you are having a liaison with a senior tertiary care center with a senior surgeon, so that you can tell that's what I've discussed, and do the wound repair with as though the patient will get vision, and send the patient immediately. So Dr. Ferenc Kuhn recommends we should do the second surgery within 6 days or 100 hours. And that's most important. And you can see here in this, the total cornea after 20 days is terrible. And we actually planned for a keratoprosthesis, but here you see Flarengar's ring was in place. And then the whole eye is necrotic. And I'm doing a open sky vitrectomy because there was no point in putting a temporary keratoprosthesis because I don't know what I was cutting and removing. it looked like a micro incision, and I had to do a anterior chamber reconstruction by removing the exudative material from the surface of the iris. You can see the entire eye is cleared of the infection as much as possible, and then a PK was done. I think the anterior segment surgeries are done by Dr. Kavita Rao in our place, and the whole idea is to remove the infection and then save the eye. And this patient, we could have done evisceration, but that was the end of it. And I think the only contraindication will be for doing this will be a panophthalmitis when there is a severe painful blind eye. I think we should not we should eviscerate, but otherwise we can do the open sky vitrectomy like this and save the eye. And then the other important problem which we can do with no perception is the suprachoroidal hemorrhage, particularly following trauma, history of injury with a cricket bat. This patient had a question mark PL, where B scan showed total closed funnel RD with hemorrhagic choroidals more in the temporal quadrant. And this is a 34-year-old male with a closed funnel retinal detachment with suprachoroidal hemorrhage following road traffic accident. You can see the corneal sutures across, and this patient was operated in a peripheral hospital in Bombay, and they said either you go to Hyderabad, Shankarnetralaya, or AIMS, or the three, and then the patient came to me, and the eye was terrible because there was suprachoroidal hemorrhage. You can see the entire retina from the temporal side was incarcerated to the nasal side, and here you're seeing the bare choroid, and the retina is totally rolled, and when I use the PSC, it's all in the suprachoroidal space and in the subretinal space. So what I did is remove the suprachoroidal hemorrhage and then use the chandelier illumination, and then I'm using 2 forceps to open up the closed funnel, almost a 360-degree retinectomy, and remove the subretinal bands which was there. And you'll see that I saw a small opening. Through that I injected a viscoelastic, and then finally used the PSCL to, you'll be seeing it, the flower will open, and the retina which looks like a closed flower where you have to open it. And so I'm now using the 2 forceps, now removing all the subretinal membranes using the retinal brush. And so here I'm using forceps to catch the 2 lips of the retina, which is closed like a flower like this, and I separate it using the 2 forceps, and then inject PFCL in between the closed funnel. You can see the retina, now you can see a small opening. I used viscoelastic, and then finally perfluorocarbon liquid through that, and you'll see the entire retina is unrolled like a carpet. So you can see now now I use the PFCL, the retina is totally attached. There are folds, so I did a gentle stroke to make sure that you need to learn the tactile sensation through the forceps so that you can mobilize the retina without causing trauma to the retina. Dr. Jovanovich had designed a retinal massager which is 20 gauge. I think we should have something like that. It's a metal blunt instrument so that we can stroke the retina to spread the retina. As you see here under PFCL, I'm spreading, and I've sometimes seen if you remove the PFCL at this stage, again it can crowd. So I didn't want to remove the PFCL, but I wanted to spread the retina under the PFCL. And you can see some part of this suprachoroidal hemorrhage in the periphery is still there, but and you can see the optic disc is there now. So it took time to, and now again injecting more PFCL to spread the retina so that the retina is flat. And then I'll do a PFCL silicone oil exchange and do a laser all around. And this patient actually got a recurrent PVR under the oil, so I removed the oil, and I did so one more, and again had recurrence, and the patient said, I'm now give up. But I think I don't give up till the time the patient is understanding. I always tell we can discuss any amount of time before surgery, but after surgery there's nothing to discuss. If you are ready, we'll operate. If you're not ready, it's okay. And if you have doubt, you can have for another opinion. And that's what I did when I went to Kashmir, because a lot of no PLIs I operated, and in the militant area, so you have to be, they were very violent, but I think, so don't give up, take risks in your life, and if you win, you may lead, if you lose, you may guide, and I keep winning and I keep losing.